Welcome to West Midlands Evidence-Based Emergency Medicine, applying rigorous data and research for optimal patient outcomes.
Welcome to The Explainer. Okay, we've all been there, right? A patient comes in with that classic Colles fracture, and you're reaching for the kit to do a hematoma block. It's almost muscle memory. But what if there's a better way? A much better way. Today, we're diving into a new study that honestly could genuinely change your practice. So we're talking about that textbook dorsally displaced distal radius fracture. For most of us, the go-to for getting some pain relief before we, yank it back into place is a quick hematoma block. But is it actually the best we can do? A new paper from Acta Anaesthesiologica Scandinavia really puts our standard practice under the microscope. And let me tell you, the results are pretty eye-opening. All right, let's get into it. Here's what we're going to cover. First, we'll set the scene. Then, we'll look at the two techniques, the old standard versus the new challenger. We'll get to the main event, which one actually works better for the reduction. Then the nitty-gritty, pain, time, all that practical stuff. Of course, we'll have a critical look at the study's weak points, and we'll wrap it all up with the big question. What does this actually mean for you on your next shift? Right. The scenario is absolute bread and butter for any A&E department, isn't it? Patient comes in, usually after a fall on an outstretched hand. The X-ray confirms it's a Colles, and our job is to get a successful, closed reduction. If we nail it, we might just save them a trip to theater. But here's the thing. Getting that reduction just right, it all comes down to good analgesia. And it's not just about stopping the pain. It's about getting that deep muscle relaxation so you can actually overcome the spasm and get things lined up. The problem is, there's no real consensus on the best way to do it, so practice varies a lot from one ED to another. So this is where a Danish study comes in. They decided to try and settle the debate once and for all. They set up a big, multi-center randomized trial with 238 patients to put two of the most common techniques under the microscope. So in one corner, we've got the good old hematoma block. It's quick, it's easy, we've all done a million of them. And in the other corner, we have the challenger, an ultrasound-guided block of the radial and median nerves, way up at the elbow in the cubital fossa. Now, this is a more targeted regional block. It's a more advanced technique, for sure. You need the skills, and obviously, you need an ultrasound machine. So the researchers, they wanted to know one thing above everything else. Which technique gives you a better initial fracture reduction? That was their primary outcome. The main event. And this bit is so important. They didn't just eyeball the post-reduction X-ray and go, yeah, that looks about right. No, they used really strict objective radiological criteria from the Danish national guidelines to define what a satisfactory reduction looked like. To count as a success, it had to hit every single one of these targets. No wiggle room. Okay, so let's get to the juicy bit, the results. For the standard hematoma block group, a satisfactory reduction was achieved in only 40% of patients. Yeah. Just let that sink in for a second. Less than half. And what about the ultrasound-guided block? A success rate of 62%. Now that is not just a little bit better. That is a huge, potentially practice-changing difference. And seeing it like this, side by side, really drives the point home, doesn't it? A 22% absolute difference in success rates. With a p-value of 0.01, there's really no question about it. The ultrasound-guided block was clearly statistically superior for getting a good reduction. But here's the question that really, really matters, right, for the patient and for the hospital. Does a better-looking X-ray in the ED actually translate to a better outcome down the line? Specifically, does it mean fewer people end up in the operating theater? And the answer from this study is a massive yes. They followed these patients, and the results are pretty striking. In the hematoma block group, 2/3 of patients, a full 66%, ended up needing surgery. But in the ultrasound block group, that number dropped to just over half at 52%. That is a really significant reduction in the need for an operation. Okay, let's move on to the secondary outcomes. I mean, a better reduction is fantastic, but we all know that in a busy department, there are always other things to think about. There's always a trade-off. So the pain scores, they tell a really interesting story. The ultrasound block itself was much less painful to perform, a median pain score of 3 out of 10 versus 6 for the hematoma block. That is a big win for the patient. But during the actual reduction itself, there was no statistical difference in their pain. So both techniques did a good job of providing analgesia when it really mattered. But, and this is a big but, here's the catch. Here's the hurdle for any busy ED. The ultrasound block took an extra 20 minutes, on average, from the time the block was done to the time of the reduction. Now, that might not sound like a lot, but when you're juggling 5 other patients, the waiting room is overflowing, those 20 minutes can feel like an eternity. And it can really mess with the flow of the department. Right. Before we all run off and start rewriting our departmental guidelines, we have to do our due diligence. We have to critically appraise the paper. Because no study is perfect, and it's so important that we understand the limitations before we go changing what we do. And you've got to give them credit. The authors are very honest about this. They themselves say that their findings, especially that impressive drop in the need for surgery, should be taken with a healthy pinch of salt. Okay, let's break these down because they are important. First, the person doing the reduction wasn't blinded. They knew which block the patient got. That's a potential source of bias. Second, the surgeons who looked at the x-rays only agreed with each other about 3/4 of the time, which kind of makes you question how reliable that main outcome was. Third, about 1 in every 8 patients in the ultrasound group needed a rescue hematoma block anyway, so it's not foolproof. And finally, most of these fancy ultrasound blocks were done by anesthesia trainees, which might not reflect the skill level of your average EM doctor. So, when you pull all of this together, what's the bottom line? What should we be thinking when that next patient with a Colles fracture walks through the door? Well, it all boils down to a classic trade-off, doesn't it? The ultrasound-guided block gives you a much better chance of a good reduction, which means fewer trips to theater, and it's more comfortable for the patient while you're doing it. But it takes longer, and it requires a specific skill set and a machine that might not be right there when you need it. And really, that's the question I want to leave you with. This study gives us some really compelling evidence that ultrasound-guided blocks can seriously improve patient outcomes, no doubt. But is it practical for your department on a chaotic Tuesday night? Well, that's a decision you'll have to make, weighing those clear benefits against the realities of your own shop floor. Definitely something to think about on your next shift.